Hi, everybody. I would like to do a little supplementary dictation since, depending on when you're listening to this, I'm dictating this on April 1st. And so the exam online April 3rd, we have one class on the 5th. I'm guessing not a lot of people will be present, and everybody will be taken off for points Easter break. So I anticipate that I'm going to have to do some supplementation anyway. So Uh, we have this chapter and three others to complete in roughly the 2.5 weeks we have left for us prior to finals. There actually will be, I'm anticipating that because the final comes up pretty darn close, we might have to get a little time in or a quick review in on the Monday right before finals. Because I have a break, I can do that then because we have it's our science day, but it doesn't start till 10, so I can do that with our class. So without further ado, this is kind of where I left off. I want to give you the Cowan PowerPoint stuff and then go back and do the Nestor PowerPoint stuff on both of these. I think it's really important. And so let's go there. So this is the Cowan PowerPoint and this is kind of where we left it. We were talking a bit about, let me get over here and get to scroll down. Basically, this is the strep throat thing, pharyngitis, sore throat. Okay, and most of the time, since they're viral, understand that viruses certainly damage cells and can cause some significant problems. They can weaken blood vessels and then they'll be leaking, and that creates problems like rash. But typically, their response to much of what viruses do is immunological. Viruses target certain cells, they alter the way that the cells produce things. Sometimes they will take a cell and make it create or release more substances that enhance inflammation, increase inflammation rather than to subdue it. So it's particularly in the respiratory area. A lot of viruses, that's what we're going to be looking at, but whether it's in respiratory or skin or elsewhere. What the virus does and the various kinds of damage that it does. And so this is classic locally, and you're not going to have permanent damage from a strep throat. The only one, and it's not included, interestingly, in Cowan's lecture, is diphtheria, which is extraordinarily important. It's still a risk, but we're immunized so successfully for it, we don't have to worry about it. So here, red, inflamed, little pustules. If the pustules are there, it typically points to strep. Again, the differential sometimes will be something like mononucleosis. So there are some things that could happen with regard to that. So it could be a common cold virus, could be mechanical irritation, but when we're looking at bacterial causes, certainly most common is group A, beta hemolytic streptococcus pyogenes, the famous strep throat strep, and it's part of a lot of different things that are there. It's a gram-positive coccus. It grows and changes. It's non-endospore forming. Sometimes they have capsules and slime layers, and again, the basis of the catalase test is from here. And again, it's not the sore throat aspect of it that's so problematic. What's problematic is if it's not treated, what can happen? Because they have the capability of producing certain kinds of toxins. For instance, they're talking about this known as scarlet fever, the erythrogenic toxin, named because it turns things red. So it's a rash, very high fever, very high fatality rate, as you can see if it's untreated. And the problem, and it's bacteriophage. It's a it's a virus that has caused, you might recall it, lysogenic conversion. Not that that's important at this stage of the game, but what it basically tells us is this is where there's some problems. Okay, and what this does, this one is unique. This is one of those super antigens. Super antigens tend to cause your immune system to go really over the top. It activates a large percentage, roughly about 20% of your helper T cells. And those helper T cells are the ones that generate a tremendous amount of cytokines. And from that is where a lot of the damage is done. Rheumatic fever is a little bit different. This is what's called a cross reaction. The antibodies actually target healthy tissue, okay, between the M proteins, which are on certain kinds of streptococci, and both heart, not so much the muscle itself, but the lining, I think is a better way to express it. And the lining of joints, that particular simple squamous seems to have markers that antibody actually targets in a harmful, not a helpful way. So, surface antigens can mimic host proteins that are there. That's one of the reasons it's virulent. So, it induces our antibodies are confused in trying to deal with it. The super antigen factor, okay, some of them have specialized appearance or structure would be a better word that resist lysozyme, which is really useful for gram positives and keeping them at bay. As you can see, teichoic and lipoteichoic acids are unique to gram positives. In this case, they can be an adherent thing. All of these are virulence factors. That M protein, okay, not only for adherence, but also, and this sort of think of it as part of a capsule as well, and that resists phagocytosis. That's a big problem. We see that particularly with Streptococcus pyogenes. So you can see the capsule as well as that M protein with that cross reactivity. So when you look, and I say it all the time, when you look at a microscope and see a staph or a strep, you see this little circular thing that's really spherical. You don't get the idea of all the stuff that's going on, all these little things that protrude, a variety of proteins and antigen causers, and the peptidoglycan and all of that stuff. There's really a whole lot more to it. So, for instance, they do also make toxins. Streptolysin O and streptolysin S are things that damage tissue. So the toxins are doing the damage. This is different than a virus. Okay, bacteria mostly work through toxins. Strep is unusual because it has toxins certainly contribute to some of its problem, but much more likely, I think, with the exception of this erythrogenic toxin, it's much more about the immunological responses that are there. Okay, and so again, they're lysogenic because of a bacteriophage infecting it. So you can see 30% of sore throats, about a third are typically strep pyogenes, the rest colds and a variety of other viral agents. You know, respiratory droplets or contact with the secretions from somebody coughs and they're in close proximity to you. Human to human, lots of different types. And so it's difficult to have an immunization because there's so many variants in these bacteria that are there. So it's a lot more difficult to try to come up with something that could be immunologically useful, let's say, in this kind of an event. Let's see what else I can tell you about it. The other thing that's there is, and I commented on it, when we see the impact in the kidney, and these are antigen antibody complexes, that's an immunological reaction, not unlike what happens to diabetics and causes their kidney problems. This causes, and when the kidneys clog up for any reason, whether it's blood or whether it's antigen antibody complexes and it's damaged and inflames, it shuts down. That's what kidneys do. That's their default for if my kidney's not working, I default into shutting down. And you'll see that again when we look a little bit more at urinary tract infections, but that's a pretty consistent finding. And even though most of the time we see this with something called impetigo, which is both a staphylococcal and a streptococcal infection, it can happen with a sore throat and the advent of a strep throat. It happened to my stepson when he was in high school, for instance, and his kidneys shut down right before he was supposed to get away on a class trip or activity out of the area, which he was able to go. It got better. So here you can see the rapid strep test we talks about. They actually use antibodies to detect it, and those antibodies are pretty much specific to that group A protein that we talked about at the start. And you can see the typical swab that we use. We use them on blood agar. You can see the hemolysis, how it's gobbled up. The red cell, that's the beta. The alpha has more of a greenish brown color that's there, and it distinguishes it. And even and the other streptococcus are non-hemolytic. Are there. You typically use different discs to identify. The bacitration disc is a very, very low concentration of the antibiotic bacitration, which you don't use, but it's particularly sensitive to streptococci that are there. And so you see that combination. That's one of the tests that you would do. The SXT is another test. That's one of those combination sulfa drugs. The cyclic AMP test. I mean, these are all, and you can look them up to see what they do. We don't have a vaccine. It's all about prevention and being watchful and just basically, keeping your distance until you start to get better and improve. Stay away from making foods. Penicillins forever have been the drugs of choice. And it's a very fastidious bacteria, which means it it takes so much to make it grow properly. It's generally fairly easy to take care of. We're starting to see more resistance. So, and I don't necessarily agree when they say cephalexin is used for patients with penicillin allergy. I will tell you this for the thousandth time. Don't come and tell anybody, well, the PowerPoint said that. PowerPoints are not subject to editorial review. When they have textbooks like this, whether it's an A&P, and I've done it for an A&P, they send you a copy of illustrations. They send you a copy of a chapter or the illustrations for a chapter. And basically you become an assistant editor. You don't get paid like an editor, but you get your name mentioned as editorial faculty for some of these textbooks, and they pay you. They get what they call an honorarium, which is a little gift, about $100 or a couple $100 to do that. And so basically, you'll give them feedback for doing this, and they put your name in there, and you can put that on your resume if you're so excited to do so. I never did. The reality is, you'd have to check for cross reaction. They put a note that we use cephalexin with penicillin allergy. In parentheses, if we knew they were not cross reactive, I might buy that. But the reality is erythromycin and Z-Pak is much more used for patients. Okay. So again, it's all about what we call the sequelae. Sequelae is a fancy word for complications. We use sequelae because you don't want to say complications to a patient. They're going to call their lawyer. Okay. More about that down the road. So this is the one I commented a little bit on. I didn't even know about it. This is gram negative. I wonder if it has something to do, maybe hygiene plays a role. Maybe it's an unusual bacteria that we see in adults. I understand this Lemire, if that's how you pronounce the syndrome, is pretty severe. It's easy, just Google the name, Fusobacterium necrophorum, and take a look at it. I assume the antibiosis would probably be very much different than this. And this gives you an idea of the typical, when we're looking at colds, there are different viruses. The rhinovirus is relatively innocuous. We have so many different types, it doesn't pay to have an immunization. Taking an immunization for something that is inherently not likely to harm you, but just to inconvenience you, is very much counterproductive. There are too many risks with immunizations causing unusual circumstances or untoward immune responses, or something called Guillain-Barré syndrome. There's Reye syndrome. There are things that could hurt you from an immunization much more so than a common cold. For years, the worst colds, the colds with the sore throat, the colds with the slight fever, because typically rhinoviruses don't have it, the colds with uh, swollen glands, typically adenoviruses, sometimes coronavirus, even sometimes relatively mild presentations, particularly in little kids, of RSV, like my kids had it. Then you have this unusual whistling sound called a croup, which is very scary for a parent, but very much self-limiting. And the reality is that a lot of the use of cool mist and various other vaporizers and moisturizing agents have been fairly helpful with regard to this. So most of the time, it's most of these come from droplets. Somebody coughs or sneezes, they're not careful unless they're in very close contact, and everybody's familiar with the symptoms. The distinction between the adenovirus and the coronavirus are probably fever and a degree of severity. We're not talking about COVID 19 in this, it's different. So when we're looking at SARS CoV 1, the original SARS COVID virus, or COVID 19, which is really SARS CoV 2, or MERS, which is Middle East Respiratory Syndrome, those severe sort of novel is the term that we use, unanticipated viruses likely with elements from other species, are the ones that provoke extraordinarily severe immunological responses. There's a little bit on this in here, and I'll give you my 2 cents worth. All of these things, sinusitis, otitis media, and my belief, particularly in adults, is that conjunctivitis come from all of these. I mean, one of my students now has conjunctivitis. They defined it as viral. About a third of them are viral, about 2/3 are bacterial. The bacterial ones are much more problematic. And they're problematic because uh, bacteria, because of the toxins, tend to cause more damage. And they would be more likely to damage your eardrum. they would be more likely to lodge and colonize and cause damage in your sinuses. They're much more problematic in the eye and much more likely to cause some type of damage, perhaps let's say to the cornea. It's not only viruses and bacteria. Yes, there could be fungi. We do see a lot of allergies, certainly, which are non-infectious effectively by nature. It's immunological. And structural problems, people with a deviated septum, relatively common. Well, we're going to see aspects of sinusitis, and it's not certainly the only factor. And so I disagree. I think you might start with broad spectrum antibiotics, but I don't think you'd go crazy over it with regard to those things. And obviously for fungi, antifungals, a lot of times you're going to looking at surgical measures to promote drainage, not so much with the eye, because the eye, and we get to this, and Cowan does eye in conjunctivitis as part of skin diseases because they're thinking of it as a surface. I don't necessarily agree with that. I think that it probably overlaps a little bit. That is there. I prefer to look at it in respiratory. You'll see that when we go back to the Nestor PowerPoint. That's there. Uh, so I mean, there's other things, and typically with sinus infections, if they become chronic, then a lot of times you have to go in there and drain those things. That's an ear, nose, and throat specialist. And the same thing with otitis media. And otitis media, again, because of the structural nature of the eustachian tube being mostly horizontal in babies, and in up to maybe between age 2 and 4, it starts to really correct. We begin to see some kids are really predisposed to these. And I mean, it just depends. As a kid, I had a bunch of them. Okay, but then they took out tonsils, which probably wasn't the best therapy. And sometimes you do have to take out tonsils, as my daughter did, despite the fact that she had 2 sets of tubes. And that brings us to the tubes. The tubes, okay, called a myringotomy. Basically, it's what it is a ventilation tube, because that's a channel that is used to relieve pressure from that area. What happens is in the middle ear, the fluid builds up, it presses against the eardrum from the inside, and inflames it. And the eardrum is supposed to vibrate. When it's inflamed and there's fluid behind it, doesn't vibrate. Then as it begins to stretch, it becomes more and more inflamed. So any pressure against it, air movement, for instance, can become extraordinarily painful, and potentially it could rupture. So when you look otoscopically, and you'll learn that those of you going into nursing or other fields where you have occasion to look, you use an otoscope. It's a special light that you can look through that will you'll look into and see the eardrum, which generally has a small, like a conical area that is very distinctive, and you see it clearly. And there's a little atomizer, sort of like a little rubber ball that you can blow air in. In the old days, our moms used to have that for perfume. It was a little bit different than the spritz bottles that we use for perfumes and colognes, things like that. You used to put that in. And when you blow that off, and you should see the vibration. When you don't, or if it provokes pain rather, then you're dealing with a problem. If that gets to the point where there's X number, I do not know what the criteria are. Is it 7 to 9 in a calendar year in a 2-year-old, or whatever it is? I'm not an ear, nose, and throat specialist. Okay. But at occasion, them using these ventilation tubes, it's a very, very quick procedure. They basically just put the child to sleep very, very quickly, lance it with a very, very tiny blade called a number 11 blade, insert this, it's a cannulated, effectively rubber tube. That cannulated means it's got a hole in it, so that air will transmit it, and it kind of like a mushroom cap, and you put it from the outside so it doesn't go on the inside, and effectively it releases the pressure. And the good news is they sort of work themselves out as the eardrum calms down and scars over, and they actually push themselves out. And sometimes, just like my daughter, you have to have a second set down the road. Just depends. So here it is: upper respiratory, middle ear. So typically it'll start viral many times and become bacterial, or sometimes not. It's interesting. Strep pneumonia is certainly the most common, and it's part of the rationale behind using amoxicillin. Because streptococci are sensitive to penicillins, if you're not penicillin allergic. And the other agent that they don't mention here is called Haemophilus influenza. I talked about it earlier. That's a normal bacteria that we find in the respiratory area, just like strep pneumonia. A fair percentage of us have it, but Those for a long time were the most common agents. H. flu, Haemophilus influenza, was one of the leading causes of bacterial meningitis in children. Strep pneumonia is still the leading cause of bacterial pneumonia in everybody. Okay, it's as a secondary pneumonia because it's in your respiratory, and if it gets down and it's encapsulated. Yes, there's some yeast, there's other bacteria and viruses. Why we use the amoxicillin, based on research done at Ioneer here in Pittsburgh, was it worked very effectively. It was broad enough spectrum to attack Haemophilus, which is a fairly, again, fastidious bacteria that was easy with most antibiotics, and the penicillin aspect of it worked very well in strep pneumonia. And sometimes you have to go with augmentin if there's a beta-lactamase thing, and that's just the way it is. Sometimes you have to use cephalosporin. And as you can see, there's some prevention now they're going to talk to. A lot of times, it's the single most important tenet in medicine: first, do no harm. So, you, to some extent, what you're trying to do with a lot of these is you're trying to observe and see if it becomes more severe. So you can use decongestants. I don't think eardrops would help, but you can use decongestants. Maybe you can try oral antibiotics prior to that, and sort of make a determination down the road. Here you can see where the fluid would accumulate here in and around and cause that eardrum to bulge, and that's the problem. Sometimes people have narrowed canals. When they're inflamed, they get more narrow. Again, they're not nearly as declinated or pointing downward as this one is. And so the Prevnar is a vaccine that's suited to this. I am unfamiliar with it because my context is when my kids were little, and so it's a whole lot different. And I don't recall I know my older granddaughter has them. I'm not so sure that my younger granddaughter has had anything, but I will check actually, etc., 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 etc. Okay, so they kind of jump around a little bit. By this time, in the Nestor textbook, they talk about diphtheria. I will make sure that you get a handle on that soon. Diphtheria is part of the 3 immunizations that we get when we get a tetanus shot. It's called diphtheria, pertussis, whooping cough, and tetanus. It's called DTaP, diphtheria, tetanus, and it's called acellular pertussis. The whooping cough part of it, which is actually part of this chapter, is a bacteria, okay, called Bordetella pertussis. So if you have a pet, like the one I'm looking at now, they have to get Bordetella shots periodically for a thing called kennel cough. And really, it's in the same kind of family, except it's much more severe, particularly in infants. Bordetella pertussis, formerly known as whooping cough, but now it's just called pertussis. But if you're talking to a parent and you say, "Why are you giving me this immunization?" Well, I'm diphtheria, tetanus shot, and also guards against whooping cough. They'll know what you're talking about because they heard of it. Well, the diphtheria is a bacteria. When we name all of these gram-positive non-spore forming rods in the respiratory that aren't diphtheria for diphtheria. We call them diphtheroids. They look like diphtheria, but they're not. Do they play a role in acne? Yes. Those are the ones on the skin. Do they play a role potentially in other problems? Yeah. For the most part, are they just normal flora? Yeah. Not diphtheria. When we get to that, you will see that it is a dread disease before the immunization and kills a very fair percentage of when, even with treatment, non-immunized people, even with prompt treatment, there's a 10% death rate for that. That's very high. Even if you're treating somebody with antibiotics, and remember, this is about a toxin, and we'll get to that. So I just want to follow the book for the time we have here. And what I'm doing now is pneumonia. And this is sort of cart before horse, I think, because we haven't covered all the upper respiratory aspects of things. But pneumonia is lower. So, and typically, pneumonias can be viral or pneumonias can be bacterial. Pneumonia, inflammatory condition where fluid of some type forms in the lung. If the fluid is purulent, which is a fancy word for pus filled, typically it's bacterial. Not exclusively, but typically. And interestingly, we look at that fluid. to determine, is it blood? Is it bloody? Is it not bloody? Is the blood swirled? Is the blood brownish or rusty colored? Because it gives you a clue. So we do a lot of culturing of sputum. And so we look for the sputum, and then we look for if it's blood or blood tinge. So the hallmark of pneumonia, and something we see entirely too much for those who are going to work in a hospital all the time. It's something you worry about constantly, because if someone has surgery, you're worried about their respiration. We do something called incentive spirometry, trying to get them to breathe so they can bring up phlegm and stuff. Particularly if they were intubated or under anesthesia for a considerable period of time, or there's some pre-existing condition. They're sedentary. When you move around and you're laying flat on your back for the most part, you're much more prone to pneumonia. And as well as blood clots and things like that. There's a whole array of bad stuff when people are in bed for long periods of time. And it's a problem. That's why most things are done outpatient. We want to get people up and moving, or get them up and moving and out of the hospital shortly thereafter. It's not just bacteria, it's not viruses. There are fungi, and they're famous. And there's a lot of problems with it. And it can be deadly. And as you can see, more children under the age of 5 die from pneumonia than any other infectious disease. This book used to have a really neat chapter on where infectious diseases caused deaths worldwide compared to the United States. And frankly, in our country, it's pneumonia, and then, for infectious disease, probably pneumonia number one, and maybe way down at the bottom is HIV/AIDS, or that type of a virus that's there. In other countries, it's the pneumonia ranks higher, and there's other infections because of the status of healthcare and certain immunizations and those kinds of things. So that's all part of it. So I think that that's all part of it as well. So anatomical diagnosis. Fluid in the lungs, you can't hear as well through it. You can see it on an X-ray. You can see it when people are bringing stuff up, that you get a pretty good idea. A lot of microorganisms. Okay, most of them encapsulated, which makes macrophages having a difficult time, or they're particularly easy to penetrate and adhere. They have a lot of mechanisms to avoid phagocytosis, and some, like tuberculosis, which is really in the pneumonia category, I think, actually grows inside of a white blood cell. So go figure. So there's a lot there. Most common, streptococcal pneumonia. Mostly we see it as folks get older, particularly with underlying viral diseases, underlying diseases like diabetes. Certainly, narcotics depress your respiration. Alcohol just depresses everything. Your immune system, you don't make as many antibodies, et cetera, et cetera. It's a mess. So we see any underlying respiratory disease, or chronic obstructive pulmonary disease, or emphysema, you're so prone to these things. And it's fairly easy to succumb, for people to die from this type of thing. And so strep pneumonia, for the longest time, maybe 60% of bacterial pneumonias in older folks or people with these underlying disorders, was the diagnosis. At least you had antibiotic treatment, if possible, for that. So that's the one to think of. There's another one that they don't have listed here that I alluded to it before. It's called Klebsiella pneumonia. You see that more in hospitalized patients because they're incontinent. And so we see, not all, obviously, but there's enough incontinence and there's enough of that bacteria around. Okay. And even associated with catheterization, they can get on the bed, what I call the bedclothes, the sheets, and the related blankets and stuff. And somebody will reach down with their hands, get on their fingers, touch their face, and then they'll inhale it. And now we got trouble. Klebsiella is a normal gut bacteria that wouldn't harm you unless you have a defective immune system. It has a very, very large capsule. It's one of the ways we identify it. And Klebs, as it's the nickname is very, very destructive. And so the difference between bacterial pneumonia with streptococcus pneumonia, strep is alpha hemolytic. It interacts with the blood. It doesn't gobble it all up. It turns it like a brownish kind of a color. So the sputum, because with pneumonia, you get blood because you're damaging tissue. The blood starts to break down and hemolyze, not completely. So that partial hemolysis, we see a rusty or a brownish colored sputum, where because you get damage and abscesses in the lung with Klebsiella pneumonia, you get a different presentation entirely that are there. I'm going to stop here temporarily because I have a dog that's creating an issue with the cat. So I will be back. Thank you.